5 key weaknesses and limitations of the health system from before the pandemic struck. At the current time, the health system is facing seismic pressures.
As we went into winter, there were growing fears that the NHS would reach a tipping point with the future of the guarantees that it provides in serious doubt.
Dealing with Covid-related deaths and ill health has put a huge burden on the NHS, with ordinary activities suspended for prolonged periods and backlogs mounting up.
By last autumn, with the cost of living crisis, food insecurity and fuel poverty were on the rise, and there were fears that deaths associated with cold and damp homes, together with waves of Covid and flu, would trigger a public health crisis over winter. Meanwhile, inflation posed new challenges for health budgets and eroded the real value of the wages of the health workforce. These fears were well founded. Around Christmas 2022, the health service was under extreme pressure, with severe capacity deficits, dangerous ambulance waits, a striking workforce and excess deaths running high.
In understanding the state of health now, it's important to look at what was happening before the pandemic struck.
Our research examines the evidence on developments between the May 2015 general election and early 2020, the eve of Covid-19, looking at public expenditure, policy developments and outcomes.
We identify 5 key weaknesses and limitations of the health system from before the pandemic struck. First, during the 2010s, the growth of public expenditure on health had slowed down considerably and lagged behind the growth of need and demand. Over the decade, the annual increases in public expenditure on health in the UK averaged only 1.7% each year. This compares to average increases of 6.6% each year during the first decade of the 21st century and 4.4% each year historically. The resources squeeze meant that the increases in public spending on health during the 2010s failed to keep pace with increases in need and demand, such as increases in the older population. In England, politicians often emphasised that the NHS England budget was being protected as part of the government's overall austerity programme, and more was spent later in the decade, especially after the NHS's 70th birthday in 2018. However, this was combined with cuts to the broader health budget, such as public health allocations to local government. Second, workforce and capacity pressures built up simultaneously during the 2010s, with mounting signs of pressure on the healthcare system and erosion of resilience to shocks.
On the latest data, there are more than 7 million people waiting for planned surgery in England. However, even before the pandemic struck, there were already almost 4.5 million people on the waiting list.
And there are other clear indications of a mismatch between healthcare capacity and healthcare need from before the pandemic. NHS workforce vacancies were running at high levels, bed occupancy pressures were on a rising trajectory, and there were regular warnings about winter pressures. It's important to look back and remember the extent of the pressures in winter 2017-18. With bed occupancy pressures at a peak, there was an unusual widespread postponement of planned operations in England, and excess deaths became a major concern when a severe flu outbreak and cold weather spell took hold. Third, policy failure during the 2010s is also part of the picture. The major drive on preventative health foreseen in the Coalition's public health reforms had not been delivered by the eve of Covid-19. The health and care systems remain fragmented, as was tragically exposed when the pandemic struck, and there was an urgent need for a major, comprehensive and sustained programme of public action to reduce health inequalities. Fourth, adverse mortality trends predated the pandemic, with improvements in mortality slowing down and stalling during the second decade of the 21st century, and mortality inequalities widening in some instances. There were indications of adverse trends in relation to heart disease deaths, excess winter deaths, infant mortality, the suicide rate, drug poisoning deaths, and deaths amongst homeless people. During the second decade of the 21st century, the progress that was being made in improving overall female life expectancy slowed down. For females in the least deprived areas, life expectancy increased, but for females in the most deprived areas, the poorest neighbourhoods, life expectancy actually fell. As a result, the female life expectancy gap widened. Fifth, avoidable health inequalities remained a major source of injustice on the eve of the pandemic, not only by socio-economic disadvantage, but also by other characteristics, such as ethnicity. These pre-existing patterns of risks and vulnerabilities from the eve of the pandemic help to explain the impact that COVID has had on different groups and provide context for understanding the further widening of mortality inequalities that has occurred. So the evidence suggests that not all of the current pressures on the health system are down to the pandemic itself, and that 5 key underlying weaknesses and limitations from before the pandemic must also be urgently addressed. Evidence also suggests that these limitations and weaknesses are not inevitable and that it's possible to turn the health system around. Going forward, we need sustainable health funding models that align healthcare capacity and supply with need and demand, as well as fully integrated health and care systems, and a sustained programme of public action to reduce health inequalities. The publication of the government's Health Disparities White Paper is a major priority. You can find more out about our research findings on the website.